So, in response to the global burden of antimicrobial resistance and the critical role antimicrobial stewardship plays in optimizing antibiotic use and reducing the subsequent emergence of resistance, our journal, Antimicrobial Agents and Chemotherapy, is excited to add a new section to the journal focused on antimicrobial stewardship studies. Combating the devastating burden of antimicrobial resistance requires novel multipronged approaches from clinicians and scientists alike. Launching this new section is an important step in disseminating cutting-edge research that will have notable implications in the global fight against antimicrobial resistant pathogens. So welcome to Editors in Conversations. The objectives of this podcast is to highlight the role of antimicrobial stewardship in preventing emergence of resistance in bacterial pathogens, explain the types of high-quality manuscript that AAC is seeking in this area, and encourage excellence in antimicrobial stewardship research. This episode is brought to you by Antimicrobial Agents and Chemotherapy Journal, available at asm.org, AAC. I'm your host, Cesar Arias, Editor-in-Chief of AAC. This podcast is supported by the American Society for Microbiology, which publishes AAC. And if you plan to publish in AAC, ASN members get up to 50% off of publishing fees. So, all these journals that is going to cost you $10,000 to publish a paper, we don't do that. We're a society journal promoting your best research. Visit our website to sign up and become a member. Don't forget to check the latest issue of AAC, available at our website, asm.org/AAC, with outstanding papers on mechanism of resistance, pharmacology of antimicrobial agents, epidemiology, and clinical therapeutics, among others. We also have a new collection in our website with all the papers published in the new section of New Perspective Antimicrobial Agents, which we actually have the editor here of that section with us, and then launch the new section that we're going to talk about. So joining us is two of the most coveted editors of the journal, Dr. Pranita Tama, who is Associate Professor of Pediatrics and Director of Pediatric Antimicrobial Stewardship Program at Johns Hopkins University in Baltimore, and of course an editor of AAC, and Ryan Schill, who is Associate Professor of Medicine, Co-Director of the Antibiotic Management Program at the University of Pittsburgh and the Pittsburgh Medical School in Philadelphia, and he's also an editor of AAC. Welcome to the program. Welcome to the show. Thank you for joining. Really, it's great. So, Pranita, let's start with you. The people who listen to this podcast is very varied. So, it comes from basic science to clinicians, and they may not understand that word in stewardship. So, antibiotic stewardship. So, can you describe what antibiotic stewardship is and explain to our audience what that is?
Yeah, thank you, Cesar, and thank you so much for inviting Ryan and myself here today. So antibiotic stewardship is basically a concerted effort to make sure we're using antibiotics as responsibly as possible. So at least in the United States, beginning in probably the early 2000s or so, some hospitals, at the beginning it was usually just the larger academic medical centers, started to develop antibiotic stewardship programs. They generally consisted of an infectious diseases pharmacist and an infectious diseases physician who worked together. Some of the main activities of the stewardship program would be to develop local guidelines to assist clinicians with selecting appropriate empiric antibiotics. So this means selecting an antibiotic before you know if the patient truly has an infection, or if they do, what the organism might be, the susceptibility pattern. So basically, your best informed guess as to what antibiotic might be most effective for that patient. And then for certain broad spectrum antibiotics, so for example, like meropenem, if a clinician wanted to use that, they would have to contact the stewardship program ahead of time to make sure the stewardship program was okay with that drug being used. And again, part of this was because we want to be careful and make sure if somebody needs anti-pseudomonal coverage or methicillin-resistant Staph aureus coverage, we provide it. But if they don't need it, we don't want them unnecessarily exposed to these drugs.
So, Pranita, just to interrupt a second, Why this happened in the 2000s? Why that wasn't an issue before? Were clinicians doing crazy things with these antibiotics, and that's part of the problem?
Yeah, I don't know exactly. I will say at Hopkins, the program actually started in the early '90s, which was one of the earliest. Not by me, so I can't take credit, but one of the earliest in the country. But I think, and I should credit John Bartlett, who's actually the one who started the program at Johns Hopkins. I think it had to do a lot with the rise of MRSA, the starting. People started to get recognize ESBL producers in the early 2000s, early mid 2000s. I think that's probably what a large impetus was. I don't know, Ryan. Do you have thoughts about why that time period?
Yeah, the specific timing is unclear to me as well, but I can tell you in our experience at the University of Pittsburgh, the impetus was a C. difficile outbreak where we had a hypervirulent strain that was causing very severe disease in vulnerable patients. And through an investigational analysis, it was very clear that fluoroquinolone overuse was driving the outbreak. And so there was a natural tendency then to try to control fluoroquinolone use. And that was really the first domino that fell in putting our restriction policies in place and formalizing antimicrobial stewardship.
Interesting.
So this is great. So in summary, antibiotics save lives, but you have to use it in the right moment, at the right time, with the right dose, and in a really good setting, because otherwise it could be harmful and will promote resistance. And this is, sort of very nice to put it, but it's a very complex thing to implement.
Yeah.
So Ryan, um, so this is becoming like an art. I mean, I always say medicine is an art supported by science. I think antibiotic stewardship is also an art that is supported by science. So why AAC? Why do we decided to launch a section on AAC, and what is the impetus behind that decision?
Yeah, for me, Cesar, and talking with you and Pranita, this really seemed like a very logical extension of what AAC's focus is, and that being the therapeutic application of antimicrobial agents. But it's in the context of antimicrobial stewardship really expanding beyond the inpatient setting into outpatient avenues and even ambulatory care. So we refer to this in our call to action paper as really stewardship without boundaries. And so we're seeing stewardship practice in a lot of different scenarios. So stewardship is growing, and of course, it's now mandatory at many of our facilities for reimbursement. I think the second point you mentioned in the introduction that's really important is that stewardship has had a very important impact on how we practice medicine, particularly post-pandemic. We saw what happened when stewardship resources and surveillance systems were rerouted because of COVID. We saw spikes in AMR across many of our hospitals. So it underscores the importance of stewardship. But I think as we look forward to AAC putting this new section in place, really, in my mind, what it does is provide an avenue for people who are already doing really good scientific work and individual investigations at their centers, an avenue to disseminate that information to our community that's deeply invested in this space. And it goes without saying that there's some really talented clinicians and investigators are doing stewardship day in and day out. Pranita already mentioned the multidisciplinary aspect of pharmacists and physicians working together. And stewardship is hard work. It's a labor of love. And so this provides them another avenue to be able to take that labor of love, share it with the community, and publish really high impact papers that are going to be seen in a high impact journal.
Definitely.
Great. So, Pranita, before I ask you what kind of papers we want to publish in AAC on this topic, whether you, in your role as antibiotic steward person in a pediatric department, what kind of examples can you tell me of things that you've done recently that may be very impactful about usage of antibiotics and that may make a difference?
Yeah, and like Ryan said, it is such a labor of love. Sometimes there's not something very novel or innovative, but it's more just the day-to-day work. What we found at Hopkins is we used to have a prior approval system. We'd call physicians or clinicians after antibiotics were prescribed. It was a lot of day-to-day work, and particularly for our pharmacist, it was quite exhausting. So what we've actually decided to do for our program is focus more on education. We publish a book that's internal, used on our intranet. There's an app. It's a couple of 100 pages long, but it's very syndrome based, because we found that clinicians seem to like to get in, rather than saying, here's a guideline on when to use vancomycin, it's much more appealing to say, these are our suggestions for how you should manage community-acquired pneumonia, from the diagnostics to empiric treatment to duration of therapy, etc. And then other things in terms of some of the tedious parts of prior approval, post-prescription review. Now in our electronic health system, which is Epic, which a lot of hospitals in the United States are probably familiar with, in that alone, when the physician, or the clinician, I should say, orders an antibiotic, automatically the fellow approves or not, the pharmacy sees it, there's a duration applied to that, so the drug will be used only for 7 days or 4 days or 2 days, so that some of that sort of challenging part of stewardship that could make it hard for the stewards is now much more automated. And we found that focusing on education, sometimes I think for groups in our hospital who tend to prescribe a lot of antibiotics, building good relations with them. So we go to tumor board every week with oncology. The cystic fibrosis group meets once a week to discuss their patients, so we join those meetings. We found, and again, it's not innovative, but we found that those kinds of relationships have been the most effective for us in terms of optimizing antibiotics and just making it enjoyable for everybody involved.
Yeah,
Pranita,
this
I
is a
think,
great point that you mentioned. Sorry, Ryan, you want to say something?
yeah, I just wanted to jump in because I think Pranita is really outlining some of the key principles that go into stewardship. And as I think about, translating stewardship into peer-reviewed manuscripts, it's important for our audience to remember that what you're doing with day-to-day stewardship is almost set up naturally like a study, right? You're going to do some preliminary investigation to identify a problem and the cause of that problem. You're going to design an intervention, targeted towards improving some sort of outcome or use of antimicrobials. And then you're going to collect high quality data to measure the effectiveness of that intervention. And this is the kind of process that we want to make sure gets disseminated in our community through peer-reviewed publications, because we can all learn from that kind of process. So as an example of something we've done on the adult side at UPMC is, we have become aware of all the newest literature and randomized clinical trials with short course treatment for community-acquired pneumonia. And when we looked at our local durations for community-acquired pneumonia, we were easily treating patients for 7 or 8 days and then discharging them on antibiotics, when really many of these patients could have been treated for 3 to 5 days. So by identifying that problem, we put an intervention in place where really we identified patients coming in with CAP, we intervened early, and sure enough, we cut down duration significantly, and we collected that data so we could show our hospital administrators and our colleagues, not only was this approach safe, but it was also effective for their patients. So there's lots of examples that people are doing this day in and day out there, and we'd love to see these examples coming into the journal so we can help them showcase it.
Great points you raise. And Ryan, I was going to ask you about, Pranita touched a point about education and communication, particularly for this field, that's crucial, and targeting those that are not ID physicians, that are not within our kingdom, put it as said, that share many of our experiences, but they are doing other jobs, right? I.e., surgeons, right? Particularly it's the surgical specialties and that we have to deal with, including high-end surgery like transplant, etc. So how do you handle that communication channel, which becomes really crucial for these stewardship measures to be successful?
Yeah, I think what we've learned is that no single way of communicating is always effective. You just have to have multiple different approaches. And so some specialties are going to be more receptive to one-on-one interactions. Others are going to be more receptive to educational materials, maybe written materials that we can provide to them. The other thing that I think is really important, and I'm sure you can both resonate with this, the education has to be perpetual. It can't end with just one line of investigation or one line of communication. It has to happen yearly or even more often for it to be effective. because education wanes over time. So you have to kind of re-up that every time. And perhaps there's new ways that we can disseminate information. I think, the other thing to be said about education in general is we now live in a world where we're doing podcasts online with each other at like 3 different states across the country. So we found another really successful way of disseminating information is to record some very succinct kind of lectures or meetings that we have, and then share that information retrospectively for people to be able to kind of consume it at their own leisure. Maybe it's in the evenings when they're out of the surgical suite or whatever it may be. So any way that you have that helps disseminate this information is useful. And my advice is to find multiple different ways to reach your targeted audience.
And along that point, Ryan, I think you've made some really good points. I also think, so for us, for example, if we make a UTI guideline, we invite someone from urology, someone from the emergency department, someone from nephrology, someone from the PICU. So it becomes a multidisciplinary group. And my pharmacist, Alice Sue, and I review literature, put together a draft where we have evidence, and then there's going to be gray areas where there's not evidence. We propose something, but we make sure everyone is in agreement, and sometimes you compromise, and there's things in our guidelines that I cringe about, that I'm like, I can't believe we have this in here. But if it's what makes the urologist happy, for example, then, it's meeting them halfway, right? You might get 80% of what you want, but it's still a win. But I do think involving them as part of the process, and then if there's some use of antibiotics that we think may not be as ideal as we'd like, it's easy to remind them that, we all came to these decisions together. Everyone was at the table. It's not us as stewards coming up with recommendations and forcing it on people. So I've found that has helped a lot with getting buy-in for stewardship. And Ryan, I don't know if you feel differently, but I've been in this role since 2012, and I think at the beginning, it very much felt like stewardship was viewed, there was antagonism, we're there to restrict antibiotic use, it's all about the costs. It feels to me that mentality about the importance of stewardship has changed, maybe because we're just seeing a lot more drug resistance and so forth, but I don't know, do you get that feeling?
No, I agree with you. It's a great point about engaging your colleagues and doing these stewardship activities. But, as a recent example, we put in place a new pathway for a perioperative surgical prophylaxis in our neurosurgery. They do a endoscopic endonasal procedure for brain tumors. And they had traditionally used broad spectrum antimicrobial prophylaxis because obviously they want to prevent anything from getting into the CNS that they can. So we were a bit hesitant to engage them, wondering what their approach was going to be. And our very first call, they said, you're absolutely right. We want to use narrow spectrum targeted agents. We provided them with some preliminary data. It was one of the easiest and most rewarding conversations that we've ever had with engaging some different subspecialties because of the points you're making. They were well aware of the collateral damage being caused by antimicrobials, well aware of resistance. So I do agree with you. I think the field is shifting, and this is now kind of a well-established practice in all of our facilities.
Beautiful. So Pranita, you are at the cutting edge of this field. So what kind of papers do we want to recruit to AAC? What is the scope of this, and what is the standards that we are expecting for papers submitted to this section?
So, I think that, as you sort of said in your opening, what we're hoping for is manuscripts that highlight innovative strategies to optimize antibiotic use across all practice settings: acute care, ambulatory care, nursing homes, skilled nursing facilities, and really from all regions of the world. Examples of articles that Ryan and I thought would be prioritized would be comparative effectiveness studies that might offer new clinical insights into management of infection. So, for example, the most effective agent, the optimal duration of therapy, whether combination therapy is needed for a particular infection. People may not think of these as traditional, quote, stewardship studies, but I think that they're critical to expanding the evidence base. And it'll make the life of stewards easier when they have these publications out there that they can reference that support their suggestions. And then I think two other areas And I'll let Ryan kind of talk a little bit about diagnostic stewardship and how that fits in. But two other areas we thought would be of interest is studies that focus on dose optimization of antimicrobials, or therapeutic monitoring studies of why they're important or not, but what we really think is critical for those kinds of studies is we do want them linked to patient outcomes. It's not quite that we dosed Vanc this way and the troughs were good. It's really more Ryan's probably shuddering at my my definition of therapeutic drug monitoring. But anyway, but we really do want to see that this is actually optimizing patient outcomes, and it's important for patient care, because ultimately, if we're trying to sell this to clinicians outside of ID, they need to show that what we're doing will actually benefit patients, and we're not just following labs and numbers. And then finally, in terms of stewardship interventions, ideally we would love to see multi-center interventions that are sustainable, and again, linked to patient outcomes. We realize that sometimes that can be hard, because again, even just working on a single center intervention can take a lot of time and work and really be meaningful. So we're certainly open to those kinds of publications as well. But we definitely want to make sure that, again, you're not just we implemented a guideline, we reduced vancomycin use, but we want to see, did that get patients out of the hospital faster? Did that improve their renal function, avoiding dialysis, or AKI and other real outcomes? Ryan, anything else you wanted to add?
Pranita, I think that was beautifully said. I mean, I think the key thing to think about in potentially submitting a paper to this new section is having rigorous methods that can be reproduced by somebody else, right? This is what we do in stewardship. We want to learn from each other's experience, but papers that are entirely descriptive or maybe very siloed to an individual setting is going to be hard to reproduce elsewhere. So we're really looking for papers that have well-defined methods, they measure an intervention, and they report key outcomes. We've become accustomed to some of the hard outcomes like mortality or other things along those lines, but there are many outcomes that are important to stewardship programs: avoiding adverse events, collateral damage, or further resistance. Many of these things can be put together, and we hope to be able to promote a lot of these secondary outcomes that are not only important to stewardship, but certainly important to patients.
Definitely.
So this is great. Pranita, there is and Ryan, and I want to direct these questions to Ryan about this concept of diagnostic stewardship, because this is kind of a little bit novel concept in the last few years, particularly with the explosion of new technologies for bacterial identification that is likely to improve and speed up the ability for the clinicians like ours to diagnose a particular infection. But of course, there is a very interesting data out there that is not only the technology, but the way that technology is communicated to the actual frontline clinician. So tell us, Ryan, what is exactly antibiotic diagnostic stewardship, and how do you implement that sort of thing?
Yeah, it's a great question, and I'm so happy that we're able to talk about it in this forum and potentially solicit papers. So I think of diagnostic stewardship in really two capacities. The first of which is avoiding unnecessary diagnostic tests. And we see this all the time in stewardship. Sending urine cultures for patients with asymptomatic bacteriuria is a good example of that, or repeat blood cultures where maybe they're not indicated. There's a cumulative toll and healthcare cost associated with all of those things. And so I think we can work with our laboratory colleagues of providing good stewardship on ordering the right diagnostic tests. The second point and the second capacity, aligned with what you're asking, Cesar, is that we've learned through the last several years that diagnostics are only as good as the interpretation that comes with them and the action as a result of that. And by putting stewardship in the middle of that decision-making process, we found we can optimize the way diagnostics are used. And so, for instance, at our hospital, any rapid blood culture results that comes from a molecular PCR-based assay, that result gets called first to our stewardship team. Our stewardship team, assesses the case, identifies what recommendations need to be made, and then calls the result to the primary care physician or team managing that case. And that partnership then between the diagnostic result and the stewardship intervention is how we're able to optimize many of these tests. And I'll just give one example where, maybe for a bug that we don't often think about, and in this case, I'll give an example with Staphylococcus epidermidis or coag-negative staph. We had a big problem at our institution, and as it turns out, if you use rapid molecular tests for gram-positive cocci in blood cultures, the most common target you're going to identify is coag-negative staph. Well, we learned that a lot of our coag-negative staph were being treated, and the reason they were being treated is our clinicians were waiting a couple of days to get that result. So what we did is we put stewardship in the middle of this. As soon as the coag-negative staph was identified by PCR, that result was called to our stewardship team, and we recommended to either stop or avoid antibiotics consistently for patients that met certain criteria. Equally as important, we recommended not to repeat blood cultures if they weren't indicated. So this gave us an advantage then that we were able to measure patient outcomes through drug utilization, but we also captured additional blood cultures that were lowered as a result of this intervention. So I think that's a good example of how diagnostic stewardship can be successful. Like antimicrobial stewardship, it's also a labor of love. These things require a lot of intensive monitoring, but if you do it appropriately, you can make a big impact on patients.
Beautifully said. The other point that I wanted to touch is about the settings. There seems to be a lot of efforts in what the inpatient settings in stewardship, but we have a big outpatient practices that which is probably much more difficult to reach, but where stewardship is probably really critical. So Pranita, can you tell us about the difference between those two settings and how important would that be to have a knowledge of how to do implementation, for example, as in outpatient practices?
Yeah, no, Cesar, you're absolutely right. I mean, I think Ryan and I have the luxury in the inpatient setting where, a patient is being followed. We know who to contact. It's much more cohesive community in a sense. To me, inpatient stewardship is so much easier than outpatient stewardship or nursing home stewardship. It's unfortunate because most antibiotics are still prescribed in the outpatient setting. So I think that there's probably like 10 to 1 the number of publications in the outpatient setting that describe the problem, and maybe out of every 10, 1 comes up with a possible solution. So I think there's a huge room for improvement there. We had attempted a few years ago to do a stewardship intervention. It included almost 500 ambulatory practices. And even defining who the stewardship team was challenging. Clinicians in the outpatient setting are increasingly busy with a lot of sort of asynchronous messages from patients through MyChart and other portals to even have time for them to get together to discuss antibiotics. But what a model that seems to have worked is during their sort of standing practice meetings that often occurs once a week or once a month, for somebody to be the quote stewardship champion, and to review antibiotic use. Maybe some things like quinolones are drugs that are probably overprescribed, but maybe not necessary. For example, uncomplicated cystitis, where there are other options and it doesn't have to be a fluoroquinolone. But I can go on this topic for a while because I realize there's just so many challenges in this area. But I do agree with you, Cesar, that inpatient stewardship has got a lot of attention, but where we really need to have more high quality studies for how to find solutions is the outpatient setting, both ambulatory, nursing home, skilled nursing facilities, where there really is still a lot of antibiotic use. Infectious disease experts are often not involved in those scenarios. So we do need to train our colleagues beyond infectious diseases. So yes, I'm with you. I think Ryan and I would both be really excited to get publications in this arena.
Ryan, any comment on that?
I mean, I agree wholeheartedly. I mean, the challenges in the outpatient scenario are multifold what they are in the inpatient scenario, because even defining the problems or getting data to assess the impact of an intervention or to know where your knowledge gaps are is very, very difficult. whether patients are getting their prescriptions filled at different pharmacies or whatever it may be. So there's a lot more questions than answers in that space. And if there are investigators out there that have found a model that is working well, I assure you there are many people that would love to benefit from the knowledge that you've gained and apply that to their local practices.
Great. So the last point that I wanted to discuss in this beautiful conversation is the global reach of our journal, and something or strategies of stewardship that may work here in the United States may not work in other places, and the other way around, right? So Pranita, why don't you tell us about that vision of having a global stewardship approach and really value sort of efforts that are outside the United States that are also effective?
Yeah, no, thank you, Cesar. I couldn't agree more that we definitely do not want this to be U.S.-centric or sort of higher income country-centric. We want international perspectives from all over the world. And using the U.S. as an example, we have the luxury of having between the Centers for Disease Control and Prevention, the Joint Commission, Centers for Medicare, Medicaid, who've all basically pushed to make this a requirement for stewardship. We also are fortunate that a lot of our hospitals have rapid diagnostics, infectious disease trained pharmacists. And at the end of the day, our burden of resistance is nowhere near other countries. So, Cesar, you were born in Colombia. I was born in India. Resistance there and what stewardship would look like is so different, right? In somewhere like India, 70% of E. coli haven't produced an ESBL enzyme. There's healthy women with their first urinary tract infection caused by an NDM producing E. coli. So how to both balance effective antibiotic therapy for patients who in the community could be at risk for very drug-resistant infections versus not furthering resistance with overly broad antibiotic use is such a different challenge than it is in countries like the US, Western Europe. So I wish I had the answer for your question about what stewardship approaches work in those settings. I realize I have the privilege of working in an area where the resources are very different, but I think it's really critical for this journal to get experiences from people working in low middle income countries so they can share this with other individuals in those settings, so that globally we have better control on the emergence of resistance. Ryan, anything else?
No, it was beautifully said. I mean, there are so many challenges out there. I mean, this is how, as a scientific community, we're able to improve global health and public health is by sharing experiences. And so I think you've nailed it right on the head that we need these kinds of studies in our journal so people can first understand the problems that are out there, but secondly, identify solutions to overcome them.
Great. So to finalize the last thoughts, let's say I am a person who is interested in a stewardship. I have a project which I think is going to be successful. What advice would you give that person to publish in AAC and not any other journal, because we are the best to publish this kind of work? Pranita, let's start with you.
Yeah, no, I mean, you have, as you could tell from the big smile on Cesar's face, Ryan's face, my face, like we're very enthusiastic about this work. We understand the importance of it. We'll be sure to promote your work. Cesar is a master tweeter. And we think that the work will be far-reaching. Our journal, unlike a lot of other journals, really does have an international community, so your experiences will be shared all over the world. And again, because this is new for us, we definitely want to promote this work and really show the global infectious disease community and beyond how important we think stewardship is. So we're very excited. We've gotten some really great publications so far to this section, and we're really looking forward to what else is out there. And if you're designing an intervention in your institution, whether inpatient, outpatient, as Ryan had said earlier, think about sort of the steps of what data you might want to collect to prove. I always use the metric of proving to others that let's say it's shorter duration of therapy, is just as effective and safer. So what kind of measures do you need? Is it days in the ICU, days on a ventilator, C. difficile? Thinking about outcomes that are measurable and realistic. C. difficile, as an example, is kind of a rare outcome. So unless you have a huge sample size, you're unlikely to show a difference there. But perhaps there are AKI or some other metrics that might make sense. So definitely think about all of that before your intervention, so it'll be easy to collect the data that you need. And again, we're very excited to see your publications.
Ryan, the last word.
Yeah, I'll just add briefly. I mean, I think for people considering AAC, please know that your papers are going to be received by like-minded scientists. The three of us on this podcast today are all clinician scientists. We're seeing patients. We're also invested in peer-reviewed publications. So your paper is going to be well received by people who understand it and can appreciate it. And our goal is to be able to share that with other people in our community that can benefit from it. And I'll just close by saying, we've talked about on this podcast, stewardship has never had such a far-reaching impact as it does now. So it's a perfect time to put your data together, whether you're a pharmacist, a physician, a nurse practitioner, a microbiologist. This is a multidisciplinary practice, and AAC is going to provide you an opportunity to share your multidisciplinary experiences and get them out there in a high-impact journal that has great visibility. So we look forward to seeing your submissions.
And if I could just add one more thing to what you said, Ryan, I think particularly people in the stewardship space often don't have formal training in study design and may not be used to publishing a lot of manuscripts. But definitely Ryan and I and Cesar are really invested in this section. So, do your best with high quality submissions. We will work with you if we think this is a good idea and meaningful to help it, if the methodology needs to be more robust, etc., with giving you the best advice possible to get your manuscript there.
Beautiful. So all the authors out there doing great stewardship, think about these editors are wonderful, cutting edge people who are have a network around the world. So your paper will be really well reviewed. We try to promote good science, good interventions. So this has been wonderful. Thank you, Dr. Tama, Dr. Shields. It's been a wonderful conversation, stimulating all the authorship. This section is going to be a hit. I have no doubt about it. And thank you very much for your time. This is Cesar Arias, Editor-in-Chief of AAC, signing off.